Well, thank you very much, Gadi. I want to thank you and everyone else for the opportunity to come here and present the Neufeld lecture. I did not know Dr. Neufeld personally, but of course I'm quite aware of his major contributions here scientifically and otherwise in Israel and throughout the world. So I think that what I'm going to do now is to begin talking about hypertrophic cardiomyopathy, which is something that I've spent a great deal of time on. But first, I wanted to make the point that this is a complex disease and you need a lot of help. And we have a family dedicated to cardiovascular disease and in part hypertrophic cardiomyopathy. My son Marty at Tufts, my son Bradley, a cardiologist at Brigham and Women's, married to Jill, and of course, most importantly, the mom, as we all know, splitting her time now between Minneapolis, which is very cold, and Palm Springs, which is warmer. Now, to hypertrophic cardiomyopathy. It is literally a global disease. It's been described in more than 50 countries and 6 continents. The disease really appears to be largely similar, remarkably, in all these different parts of the world. And in fact, the prevalence of hypertrophic cardiomyopathy is based on a number of studies from different parts of the world, about 1 in 500 of the general population. That would mean that there would be 600,000 affected individuals in the United States, about 15,000 here in Israel. And many of those individuals are at risk for sudden cardiac death and may not know that they have the disease at all. In fact, all of us see only the tip of the iceberg. We are only characterizing the disease by those relatively few individuals among the general population of HCM that come to attention. Most of the disease is under the surface, and one of the challenges of this disease in the future will be the identification of more and more patients, many of whom will require attention, many of whom will not. The key word to describe hypertrophic cardiomyopathy is this heterogeneity. If you don't understand the disease in this context, it's very difficult to understand its diagnosis and ultimately its management. Heterogeneity goes directly to the phenotypic appearance of the heart that we see with two-dimensional echocardiography and now more recently with magnetic resonance. Massive hypertrophy, segmental hypertrophy involving only a small area of the left ventricular wall, can be anywhere including the apex. All of these patterns of left ventricular hypertrophy are in fact part of the disease spectrum. And this hypertrophy that we all focus on for diagnostic purposes, of course, is a dynamic feature of the disease. By that I mean that there are changes in left ventricular wall thickness, mostly occurring during adolescence, but now we realize that wall thicknesses may increase. The hypertrophy may even appear for the first time in midlife and even beyond. We have the appearance of left ventricular hypertrophy up to the age of 70. In some examples of these patients, you can see here a 27-year-old female, family member, no hypertrophy, then spontaneously, just a few years later, with no apparent trigger, develops massive hypertrophy and requires primary prevention with an ICD. Again, this is the heterogeneity that occupies many decades of life. There's been a major contribution by magnetic resonance in this disease in a number of ways. One of them is diagnosis. Here is a family member with a normal echocardiogram, no apparent wall thickness, but magnetic resonance is capable of detecting segmental hypertrophy in certain areas that are undetectable reliably by echocardiography. And you can see the anterolateral free wall is in fact an area that is blind to routine echocardiography in some instances. This is a diagnosis, therefore, in this individual could not have been made without MRI. Now, what is this disease? There's still considerable misunderstanding, I think, about the natural course of hypertrophic cardiomyopathy. These are our data from the upper Midwest. And the point to make here is that hypertrophic cardiomyopathy, total mortality shown in yellow, compared to the US health statistics, which is all risks, no difference statistically between the two. In other words, HCM does not add to the risk of living for the overall HCM population. You can see that the annual mortality is about 1%. That's quite different from the old days when there was a characterization of this disease of 6% per year mortality. That is not the disease. But again, I'm emphasizing here the overall disease spectrum. We'll get into the subsets. And part of that is that HCM is compatible with normal life expectancy. It's a very important principle for many patients who may not need treatment to prolong life or even improve the quality of life. In fact, about 20% of our patients in our cohort have achieved age 70. And we even have patients, 2%, that are 90 years of age or over with the real hypertrophic cardiomyopathy. So it is a strange disease in a sense. It is the most common cause of sudden death in young people, and in fact compatible with not only normal longevity but extended life. Now, how do we approach patients with this disease? Heterogeneous, complex. We have to understand that there are a number of profiles of prognosis that patients may assume. 20% develop atrial fibrillation, which requires its own management. Then there is symptom progression, which is essentially heart failure, occasionally leading to the end stage with systolic dysfunction and the requirement for heart transplant. But of course, the most visible complication of HCM has been, for 50 years, the risk for sudden cardiac death from the first description by Donald Tier in 1950. So let's talk about sudden death. It's on all the patients' minds as well as their physicians, and it appears to be somehow related to this underlying substrate that we recognize by looking at the disease muscle with a microscope. The disorganized cardiac muscle cells, you can see that the adjacent cells are arranged in perpendicular and oblique angles to each other. It's a unstable appearing electrophysiologic substrate, certainly, and may be responsible for the unpredictable ventricular tachyarrhythmias. Then there is the small vessel disease, the intramural coronary arteries that are narrowed and produce bursts of myocardial ischemia, leading to cell death and then repair in the form of fibrosis. So between these areas of fibrosis and the disorganization of the architecture, this is probably the arrhythmogenic substrate. The risk for sudden death is not identical throughout life. In fact, as I think we're all aware, if you look at the pink bars, that the risks are higher in young people, less than about age 25 or 30. This is the predilection age for sudden death in this disease. We don't understand why there would be this difference, but it is not only evident here, but in many studies. And then if you follow the pink bars, you'll see that they do not extinguish. That means that there is a risk for sudden cardiac death in this disease that extends into midlife. And in fact, there is no single age that conveys a immunity to this risk for sudden death in HCM. And as the most common cause of sudden death in young people, our data in the United States at least will place HCM as the single most common cause of the athletic field deaths. These highly visible tragedies are caused by a variety of diseases that we're all familiar with, but this is the single leading cause. These are data that are different, that come from Italy, of course, but I think that's a very select circumstance. So HCM, most common cause of sudden death in the young as well as the trained athlete. So the focus is to identify those patients that are at increased risk among this vast population, because those may be the patients that deserve consideration for prevention of sudden cardiac death, which we can offer at this time. The risk algorithm is shown here. These are our 5 major and conventional risk factors that everybody agrees about. Any one of these can be enough to place a patient in the highest point of the pyramid, and therefore at least consideration for an ICD. There are other factors in this disease that can be used as evidence of increased risk and may place a patient toward the upper part of the pyramid as well. I will talk about some of these, but we don't have time to talk about all of them. But the massive hypertrophy certainly is a risk factor. There is no other disease that produces this degree of left ventricular hypertrophy, up to 50 millimeters is shown here. We always have regarded this as something unique and worthy of consideration for risk, because these data here sort of substantiate that. Measuring maximum wall thickness against the risk for sudden cardiac death, you can see that there is almost a linear relationship between wall thickness and risk. And in fact, here on this part of the diagram, the most extreme hypertrophy, 30 millimeters or more, constitutes the highest risk, and we regard this as a risk factor. Over on this side, the absence of significant hypertrophy, mild hypertrophy, is a low-risk feature of this disease, assuming there are not any other confounding factors. So hypertrophy counts, particularly if it's extreme. It turns out that age counts as well as an anti-risk factor. This is a different disease than coronary artery disease. Basically, patients live with HCM for decades. And it turns out that if you take patients that are presenting for the first time at 60 years of age or more, with or without risk factors, their risk for sudden cardiac death without a defibrillator is exceedingly small. So age works in favor of the decision-making for ICDs in this disease. We're talking about 0.2% in this patient population over the age of 60, which is certainly young enough in the context of coronary artery disease for defibrillators. Well, we're 20 years into the genetic era, and the reality is, despite all the promise that mutational analysis would predict which patients were at increased risk, this has not turned out to be true. And there is a good reason. The heterogeneity is the reason. There are now 11 or more genes, certainly, and more than 1,000 mutations among those sarcomeric mutations, genes. So you can see that the idea of picking out which patients were at increased risk, predicting the future, predicting prognosis based on the identification of a mutation is in fact impossible. We use genetic testing for family analysis. determine affected members and families, but not to make clinical management decisions. Making it even more complicated are the non-sarcomeric mutations creating phenotypes of hypertrophic cardiomyopathy. Patients with hearts that look like HCM but do not in fact have HCM. One of those of greatest importance is the LAMP2 cardiomyopathy. LAMP2 is a lysosomal storage disease, and this actually was one of our patients. The very thick heart, weighed more than 1,400 grams, septum 65 millimeters. This is probably the thickest and largest heart we've ever seen with a hypertrophic cardiomyopathy. But it is not the sarcomeric version that we're always talking about. You can see this vast fibrotic areas staining blue, and the distorted myocytes containing lysosomal degraded material. It is a profound disease for which the defibrillator does not work, as you can imagine. This is a completely different substrate. It is refractory to effective ICD therapy, and it is not compatible with survival more than about 25 years, as far as we know. So it is a heart transplant consideration early. Now, while I've said that genetic testing has not proved to be useful in predicting the future, there may be some hope for it, but it would have to be in terms of double mutations. There is accumulating evidence that 2 sarcomeric mutations might be better, or might be worse, I should say, than 1. This is one of our patients, a young man told to not be at risk because he had none of the risk factors. He survived a cardiac arrest with therapeutic hypothermia and is completely intact. After that event, we found that he had 2 sarcomeric mutations, again, in the absence of any other risk factors, and he apparently inherited those, 1 each from each parent, who both had hypertrophic cardiomyopathy, a situation we have never seen before. 2 clinically affected individuals producing this young man, each devoting 1 of the mutations and creating what is probably a high-risk situation. There's a lot of work that needs to be done on double mutations, but I thought I would mention it as a potential for the future. Just as late gadolinium enhancement is considered a possibility for the future. These areas that we believe represent fibrosis in vivo with contrast MRI are associated with arrhythmias. These are ambulatory Holter arrhythmias, and you can see that the patients that have delayed enhancement have more in the way of these arrhythmias, particularly the non-sustained ventricular tachycardia, which is, of course, a risk factor in this disease. So this would suggest the possibility that recognition of these areas presumed to be fibrosis may be the next big risk factor, but right now, at this point, there is no evidence of that. These are our data in follow-up looking for actual events. And we find no difference between the patients that have delayed enhancement and those that do not have delayed enhancement. So even just the presence of fibrosis does not seem at this early point a variable that can separate patients in terms of their risk. This is all about the idea of prevention of sudden death. When I started in this disease a long time ago, we really had nothing for these patients, and in a relatively short period of time, we actually can aspire to interfering into the natural history of hypertrophic cardiomyopathy. And of course, anytime I talk about this, I have to remind us all about Michelle, who created, with Morty Maurer, the implantable cardioverter defibrillator. Of course, Dr. Morawski had no idea about hypertrophic cardiomyopathy. this is something that, of course, we had to pick up subsequently. You may be interested to know, historically, that of the 3 patients that represented the first publication showing that the ICD worked in the laboratory, that it could abolish ventricular fibrillation induced under those conditions, that 2 of the 3 patients actually had hypertrophic cardiomyopathy. And this was largely because the FDA required Dr. Morawski to recruit only patients who had survived 2 prior cardiac arrests. So it was difficult to find patients. And at that time, 2/3 of the first 3 had HCM. And for the next 20 years, the genetic heart diseases were pretty much forgotten as the ICD developed in the patient population with coronary disease, as it should have. We have assembled data that looks at the efficacy of the ICD in HCM. This is our large registry of over 500 patients, and basically what we have found is that after a relatively short follow-up period following implant, 20% had appropriate interventions for VT-VF. This is a higher annual shock rate for secondary prevention, which is understandable. For the key population with primary prevention, it was actually quite high as well at 4% per year. 4% is, when multiplied out over the long time period, becomes very large. The average age of these events was only 42 years. So we have, I think, shown that the ICD is capable of changing the natural course of this disease for many patients, as long as we know which ones deserve consideration for the ICD. And there has been a lot of controversy about that. Some of our European colleagues have suggested that you need 2 risk factors or more. But that has never seemed intuitive to us practicing in the United States. And these data support the idea that 1 risk factor can be enough. You can see that there's no difference in the frequency of appropriate shocks, whether the patients were implanted for 1, 2, or 3 risk factors. In fact, 1/3 of the appropriate interventions were in patients implanted for only 1 risk factor. So 1 can be enough. The idea of depriving ICDs to patients because they only have 1 doesn't really make any sense in this disease. Now, the time period between the implant and the first shock can vary considerably. And I want to direct your attention to the fact that it can be long, 5 to 10 years. So these are patients that had devices that were dormant for up to a decade. And that is a function of this disease, of course, the unpredictable substrate that I talked about, because when risk is detected, discussed with the patient, then our hands are really tied. Can't tell a patient to come back in 3 years and we'll discuss the risk for sudden cardiac death again, because we don't really know what will happen, obviously. So this is an important idea. I have cardiologists tell me all the time, I implanted a device and it's been 2 years and nothing's happened. You have to wait because we don't know how to judge that unpredictable substrate. And it is, in fact, a principle of the ICD and ICD therapy in this disease that we're dealing with something that is very unpredictable. Now, does the device work? This was the first question in HCM because, again, Michelle never had a disease in mind with left ventricular wall thickening, sometimes extreme outflow tract obstruction, myocardial ischemia, diastolic dysfunction. It's a complicated disease, and we didn't know. But it turned out that the ICD did work. There were patients that died, for example, in the end stage, which is similar to end-stage coronary disease with scarring. And we have only one example of a typical young patient who died despite the device being in place. And this is the basis of the so-called Guyton affair. It's a young college student who died because his device short-circuited and did not deliver a defibrillation shock into the heart. Unfortunately, this defect was known to the company and not known by the physicians, or the patients, the implanters. It was kept as a secret and resulted, when no longer a secret, into the largest scandal in the ICD industry history. But that's our only example of a failure. Now, there may be others out there. We just don't know about them. And I think anything is possible in this disease. So what about heart failure? To conclude, and this is exertional dyspnea without or with chest discomfort. That's basically what we're talking about in a patient with a preserved ejection fraction. And our approaches are very different. We start with drugs, of course. We don't have very many, but it's the beta blockers, verapamil and disopyramide, basically, sometimes with diuretics, judiciously. These are the drugs that are used to control these symptoms as they appear, to afford a reasonable quality of life for patients. If that control fails, we have refractory symptoms. Over here, in the non-obstructive form of the disease, is really only one option, unfortunately, and that is heart transplantation. Most of the activity in the literature, most of the discussion, concerns the patients with left ventricular outflow tract obstruction and refractory symptoms. That's the group that has become controversial, even though it is relatively small. Now, we know that obstruction counts. I told you hypertrophy counts and obstruction counts as well. You can see these data showing that for progression to severe heart failure, there's a big difference in cumulative survival with obstruction versus the absence of obstruction, with a relative risk of over 4. So with time, there is no question that many patients, not all, will develop heart failure symptoms because of obstruction, which means because of elevated left ventricular pressures. I want to caution you in this regard because many patients have provocable obstruction with exercise. That's physiologically provocable, and we don't know the significance of these gradients in every case. Sometimes they are associated with severe symptoms, but many times they appear on stress echocardiogram in patients who have no symptoms. In fact, if you add together rest obstruction with physiologically provoked obstruction in a consecutive population, 70% of patients will have developed gradients, either at rest or with exercise. So this is an obstructive disease in that sense. But when we talk about management in this section, we're talking about obstruction plus refractory symptoms, for which the gold standard is surgical septal myectomy still. This is the conclusion of all consensus panels. There is going to be an American Heart Association ACC guidelines published in about a month. Makes the same conclusion as the consensus document in 2003 that Gotti mentioned. So we have almost 50 years now of experience with the surgical myectomy. The mortality rate is now very low at experienced centers, far less than 1%. So this has become a low-risk operation in the right hands, as it turns out. and will abolish obstruction and will restore quality of life. Now, we've always operated on patients to restore quality of life, but now we know that in addition, there is evidence here based on this Mayo Clinic series that surgery contributes to longevity, because the operated patients are on the same survival curve, this is total mortality again, as the general population. Total mortality, 83%. If we limit that to cardiovascular mortality, it'd be 92%. All of which is distinctly different from a quote-unquote control group of patients who had obstruction were not operated on with very different total mortality. This is not a randomized study, of course, and which is impossible in this disease, but I think the point is clear that surgery has been shown to improve quality of life and extends life as well. Now, the competing treatment is the alcohol septal ablation, which I think we're all familiar with. I don't need to describe it to you in any detail. All the consensus panels agree that it is a selective alternative in those patients who are not operative candidates. You're probably thinking, but we don't have a surgeon here in Israel. What do we do then? Now, this is the most common question, and the answer to that is create one. It's a country of 7 million. A single surgeon experienced with the myectomy operation would be sufficient to receive referrals for this operation, which is not particularly common even in the spectrum of HCM. Now, alcohol ablation is being pushed very hard and has been for several years by the interventional community. There was a discussion earlier about choices for patients. If surgery is not available, then patients don't really have the choice of the gold standard, in fact. And the issue really is this scar that we are concerned about, because it's not small. It's a transmural scar. It occupies, on average, 10% of the left ventricle and about 1/3 of the septum. Over here, in comparison, this is a much different approach because there is no intramyocardial scarring. So there's no scar here and a large scar there. They're very different techniques, and with different consequences, at least potentially. And one of those consequences is arrhythmias. If you just use the literature that we have, because there will never be a randomized trial comparing surgery and ablation, there is about a 10% risk for life-threatening ventricular tachyarrhythmias among all these studies following, usually short-term, following alcohol ablation. The long-term risk of the procedure is going to be difficult to define, for sure. So my final slide, I think, is in fact the most important, because if you take a look at the 50-year history, even the 30-year history of this disease, there has been a distinct evolution from a disease that was often considered hopeless or untreatable. Certainly the risk for sudden death was untreatable. When we started with hypertrophic cardiomyopathy, all we had were beta blockers. At this point, however, it is and can be regarded as a highly treatable condition. In other words, all the complications of HCM are treatable. And this is what I tell the patients. Treatment for atrial fibrillation, we're all familiar with, as it is today. I talked about heart failure. the drugs, the myectomy, and the selective alternative for patients who are not operative candidates, the alcohol ablation, particularly those over the age of 50 or 60. Occasional patient has no option other than the transplant when they develop systolic dysfunction. And of course, over here, the idea of protecting patients with the implantable defibrillator, which we hope at this early stage is a way to achieve normal life expectancy despite that unpredictable substrate. And finally, the majority of individuals, either identified or not identified, with this disease probably need none of this and can reach normal longevity without treatment and sometimes without even knowledge that they have or are affected by hypertrophic cardiomyopathy. Thank you very much.